epilepsy is an extremely broad category. Or having seizures is not the same thing as epilepsy. Epilepsy is actually defined as 2 or more seizures that are unprovoked. By unprovoked, what I mean is, what is meant by that definition is there's not a acute reversible situation. So for example, if somebody comes in, if somebody has a seizure because their glucose is 35, that would not count towards this. Okay, or if someone has went out on an alcohol binge and had a seizure from that or withdrawal, that wouldn't necessarily be epilepsy. So these have to be seizures that are not provoked by something that is reversible. Okay. To oversimplify dramatically the mechanism of epilepsy, it's just increased spontaneous neuronal firing. Okay, and it's a fairly common problem. Approximately 1 to 2% of the general population has epilepsy, but many more than that actually will have a seizure sometime in their life. But it's estimated that about 1 to 2 million people have epilepsy in the United States. Okay? And there are approximately 70 to 130,000 new cases each year. This graph here shows the incidence of epilepsy by age. You can see that the most common age group is the elderly, and probably the second most common would be the very, very young, and middle-aged people, 20s, 30s, 40s have the lowest rate. Basically, we'll talk about some of the causes for these later on as we become apparent. The risk factors for epilepsy. This is something we hardly ever see because it's so rare. But if you've had severe military head trauma, then you have an extremely high risk of having seizures. They say that if you have a loss of consciousness, and we get a lot of patients that we see in the clinic who, and we always ask these questions. All these questions should be asked by a doctor who sees a patient with seizures, except maybe this one. But I mean, it's important to know. But if someone says, oh, if I ask a patient, have you ever had any kind of head trauma in the past? They may say, oh yeah, this happened. A lot of times they say, yeah, I had head trauma in the past. Well, what happened? Well, I fell off my bike and I bonked my head. Did you lose consciousness? No, I didn't lose consciousness. Then I don't even pay any attention to that. So mild, really super duper mild head trauma is extremely unlikely to cause a seizure. If they've had loss of consciousness for up to 30 minutes, then that's sort of where I start to think this could be a significant risk factor for epilepsy in the future. So a more sustained loss of consciousness has a higher rate. Seizure classification, we divide them up into two types, partial and generalized. And really, actually, a very simple distinction. Partial seizures are those that originate from one locus of the brain, one part of the brain. Generalized start in all parts of the brain at the same time, like that. Okay. There are 2 types of partial epilepsy, or partial seizures, I should say, simple and complex. Again, a very straightforward distinction between the two. Those seizures that are simple partial, the patients maintain full awareness during the event. Okay, they can have a whole variety of manifestations or symptoms during the event. Classically, they might have some twitching, so a motor partial seizure. They can have a sensory partial seizure. They can have autonomic partial seizures. They can have, basically they have wild fluctuations in blood pressure or heart rate, things like that. They can have psychic partial seizures, like a deja vu type of thing, okay? So they can have a whole variety of different types, but the sort of classic ones would be motor. In other words, the ones that people are most familiar with. And then there's another type here, partial seizures with secondary generalization. All that means is the patient started with a partial seizure, one that was kind of in one part of the brain, originated, and then rapidly spreads to include the entire brain. And that's actually fairly common. And the reason why there's a distinction made here is because these patients with be treated differently than these patients. Even though you may only witness a generalized seizure, they would be treated slightly differently than these. For generalized seizures, you've all heard of the absence seizures, or people call them petit mals. Some people call them staring seizures. Okay, we'll talk a little bit, talk more about what happens in absence. Myoclonic, all that is the jerk. Okay, the kind of jerk that we've all had, at least I've had. You know, when you're falling asleep. Okay, but these happen. Those are not seizures, obviously, but these people can have seizures. So this is a jerk. It can be a full body jerk. It can be a leg jerk. Tonic seizures, stiffening of the body, basically just stiffening. Atonic seizure, also known as drop attacks or drop seizures, where they just lose tone, hence atonic. And literally they will go down, just like that. And I've seen video of it. It's really, I've never actually seen a patient who has it, but they will literally be walking and then they drop. And it's really quite scary. Clonic seizure is basically just the convulsing, classic convulsing seizures. And then the tonic-clonic are the ones who have a combination of tonic and clonic. And we'll talk a little bit more about that too. So about 1 in 10 of us will actually experience a seizure at some time in our lives. But again, that's not epilepsy. Only 10% of the 10 to 20% of those people will actually go on to develop epilepsy. Okay. So the question is, when someone comes in with a first-time seizure, do we start treating them right away? And the answer is typically no. But there are exceptions. There are no hard and fast rules. So it really depends on what we think their chances are of developing further seizures. Okay? Now, once they've had a second seizure, then that meets the official definition of epilepsy, and we do treat that person. The question is, what are some of the things that lead to a second seizure? Or what are some of the things that would make us treat that person even though they've only had one seizure? So if we get an EEG, particularly within the first 24 hours, it was the highest yield. But if we get an EEG after someone's had a single seizure and they have epileptiform discharges, that patient will oftentimes get treated. And we will start to treat them, regardless of whether or not they had a second seizure. If someone has a bleed in their brain, that patient will be treated. If someone had a concussion, they will warrant at least some treatment for a period of time. Maybe not lifelong, but for at least a week. Those patients will get treated, even though they just had one seizure. If someone's ever had a stroke and they've had one seizure, that patient will usually get treated, okay? But everyone who doesn't fall into that category will probably not get treated after a first-time seizure. Someone with a seizure is not necessarily a benign thing to do. There are a lot of side effects. Even the safest drugs have side effects. So, and just carrying a diagnosis of epilepsy, being on seizure medication, can cause lots of problems for a patient. Finding a job, getting insured, being able to drive. So you don't want to necessarily commit someone to being treated with an AED unless they have a high risk. And this was pretty classic data that showed that why we do that. Patients who have a first-time seizure without an obvious reason only have about a 30 to 40% chance of going on to have subsequent seizures. But once they've had that second seizure, their chances have jumped up to about 70 to 80%. Okay, second and third seizures. But the history is the most crucial part by far. The neurologic exam is oftentimes stone cold normal, but you still do one. EEG, again, you only have a 50% sensitivity on that first EEG, but it's still an important test because you might find something, and you repeat it if you don't. And an MRI of the brain, absolutely essential. Okay? Sometimes you need to do something like a lumbar puncture if you suspect they could be infected or have something else going on, usually infection. But usually it's just an EEG and an MRI.
What shows up on an MRI if somebody's epileptic and they don't have like a tumor or an infection?
You name it, they could have it. They could have, for example, mesial temporal lobe sclerosis, which is why we do the thin sections. They could have an abnormality of development. So just a congenital brain abnormality that was not known before. They could have, they could have encephalitis.